Good afternoon. Thank you so much for the invitation to speak at this event. Today I'm going to share results from our trial entitled Rebuild, which is a virtually supervised resistance exercise intervention for non-metastatic pancreatic cancer patients. And specifically, I'm going to focus on enrollment trends. My name is Christina Dieli Conwright, and I'm an associate professor at Dana-Farber Cancer Institute and Harvard Medical School. Jump right in. The first couple of slides here are a disclaimer, if you will. They describe the paradigm at which I view exercise and is the focus of my research laboratory. So actually what we do is we use the translation of sports science to exercise as medicine, and that involves the application of training principles from sports science being applied to clinical populations. So in order to do this, we think about the parameters on the left that we draw from sports science: goal-focused, performance testing, periodization or progression of training, and oversight by qualified trainers. We take all of those components and we're easily able to apply those to individuals who've been diagnosed with cancer. Our goal would be our primary outcome. We do performance or fitness testing in order to understand an individual's baseline health. We progress exercise over time, and we use integration of cancer exercise trainers. Additionally, the goal of our research lab is to optimize treatment outcomes and reduce comorbid conditions with exercise among cancer survivors in an effort to progress exercise oncology research. Here you see on this particular figure the trajectory of health outcomes over time. Traditionally speaking, we would see health decline potentially as a result of the cancer itself or the treatment toxicities. That's shown in the red dashed line. In the dashed purple line, we see that these health outcomes are further worsened in minority populations, such as Black and Hispanic populations. So we use exercise, which is displayed in the solid blue line near the top, to uplift those health outcomes in our laboratory. And we do so across the trajectory: prehabilitation, immediately post-surgery, during chemoradiation, or post-treatment. I am the principal investigator of this particular study, along with my senior staff scientist, Dr. Rebecca Wilson. We have excellent research coordinators who collect our data and lead the trial on the ground with the patient-facing activities, Mary Norris and Danny Wynn. And our faculty co-investigators include Dr. Brian Wolpin, Michael Rosenthal, Jeff Mayerhart, and Hajime Uno, all at the Dana-Farber Cancer Institute. The Rebuild trial is focused on targeting skeletal muscle mass. We know that cachexia is highly prevalent in patients with pancreas cancer, and that low skeletal muscle mass is a strong predictor of poor physical function and shorter survival. Resistance exercise is one strategy to aid in the preservation of skeletal muscle mass, yet this approach remains largely understudied in this population. Further protein supplementation may help to augment protein synthesis when combined with resistance exercise, or perhaps diminish the rate of tissue wasting. Therefore, we are conducting a randomized controlled pilot study to evaluate the impact of resistance exercise with and without protein supplementation on skeletal muscle mass in this population. Our first aim is to evaluate feasibility of our intervention. Our second aim is to determine whether we can alter skeletal muscle mass. Our third aim is to investigate the impact of the intervention on plasma biomarkers associated with tissue wasting. And our fourth aim is to look at the impact of the intervention on physical function and psychosocial measures. Here's our study schema. We recruit internally at the Dana-Farber Cancer Institute. We screen patients who are diagnosed and come to at least one medical oncology visit. Then if they're interested in enrolling, we perform the informed consent. We conduct baseline measurements. Then they are randomized to one of three groups: resistance exercise plus protein supplementation, or attention control. The intervention lasts up to 16 weeks. In other words, the first 16 weeks of chemotherapy, but can be reduced to shorter based on chemotherapy duration. And then we complete post-intervention assessments after. If individuals are assigned to group 3, we then provide them with the option to join the exercise intervention. Patients receive $50 gift card per visit, and they get to keep all of the exercise equipment, such as the resistance bands and the Fitbit. Specifically, our eligibility criteria includes non-metastatic pancreatic cancer patients receiving neoadjuvant chemotherapy. They're within 4 weeks of initiating chemotherapy. they're overweight or obese, they receive clearance to participate in exercise. Study is open to individuals who speak English or Spanish. They're sedentary, willing to come to Dana-Farber for data collection, and of course able to sign the informed consent. As far as recruitment approaches, we certainly engage the gastrointestinal clinical team. We attend in-person clinical visits when appropriate and tumor board meetings. We also present at monthly research meetings. We then screen through direct patient lists organized by the GI team, or we also accept direct referrals. This could be from DFCI websites or the Community Engagement Center. We seek permission from providers to contact patients if needed. And then we also ultimately schedule baseline assessments if patients are interested in consent. Because this study requires individuals to come to Dana-Farber, we focus particularly on patients of Dana-Farber, but don't restrict by that. Here is an overlay of the interventions. As you can see, all are overseen by health professionals. Resistance exercise is 3 times per week at moderate to vigorous intensity. The exercise sessions last about an hour. And the groups that are receiving protein receive 14 grams per day of protein, which is approximately 2 scoops of the whey protein supplement that we use. Attention control group receives a stretching program and again can receive the exercise intervention if they choose. Feasibility, we're looking at intervention engagement, attendance, and compliance to exercise. Skeletal muscle mass is assessed by CT scans that are standard of care and are analyzed by Dr. Rosenthal's team. Plasma biomarkers include IL-6, MCP1, TNF, and branched-chain amino acids, as well as fecal elastase from stool samples. Patient-reported outcomes and physical function include quality of life, fatigue, depression, sleep, pain. And we have a battery of physical function tests, including hand grip strength, sit to stand, muscle strength. Here's an overview of our study calendar. For the most part, patients are really suggested to come to us at 2 times, at week 1 and at post-intervention. And the mid-intervention testing is optional. That is more prevalent if they have chemotherapy for an extended period of time. Data collection tends to take approximately 3 to 4 hours and therefore does take into effect that the ask and the burden of this particular study can be moderate to high given they're undergoing chemotherapy. So here's an overview of reasons for eligibility, and this really highlights, the last 3 slides are going to highlight what we've noticed in enrolling patients to this particular trial. As you can see, we have the majority of our patients who are actually not metastatic. They are actually coming to Dana-Farber with metastatic disease, so there's a large population of patients who are not eligible. We also screen broadly across GI cancers, and so you can see there that there are also individuals who are not diagnosed with pancreas cancer that we are screening. Then we also have a high volume of individuals not planning to undergo chemotherapy, or perhaps they've already undergone 3+ cycles of chemotherapy. So in other words, many of the reasons for eligibility are clinically related, that are factors that are difficult to control from our standpoint. One of the main reasons we're not including metastatic patients in this particular study is because we have very successful therapeutic drug trials that are ongoing. One was recently presented at ASCO 2026 meeting a few weeks ago that showed fantastic results on survival, and therefore we decided to not co-enroll and compete with those particular trials. So reasons for decline, I think, is particularly interesting. You'll see that the main reason is overwhelmed with diagnosis and treatment. Coming in second is logistical issues with timing and scheduling to be able to come to data collection and the intervention. Coming in third is they're just simply not interested and no further information was provided. Coming in fourth is they cannot commute for the study activities. And fifth, rounding out the top 5, is they just did not respond to any of our communications. These are pretty common reasons that we see across the board, ultimately simplifying down to the fact that committing to a clinical trial, regardless of exercise or other lifestyle intervention, can be burdensome due to the time commitment and the time needed to commute. And lastly, I wanted to share our consort diagram because you can see, and I recognize this is a bit small, you can see that we have actually screened thousands of patients for this study. So unfortunately, we do not have a shortage of patients that we can screen. But ultimately, in order to yield the number that we have consented, you'll notice that it's less than 10% actually sign up for the study. Thankfully, we've been able to retain some of our patients on trial. We have lost some to follow-up. We have also lost some, unfortunately, to death during trial. And we do have a few patients still on study that we're wrapping up now, but accrual has effectively ended for this particular study. So a few takeaways that I want to emphasize. First and foremost, this was not an easy study to accrue patients to. Enrollment was quite complicated. Patients are quite burdened by the diagnosis and by chemotherapy. For those who did participate, we do have individuals who were able to achieve high exercise compliance, and that was fantastic to see. No adverse events to exercise to date, so no safety concerns. Hopefully next time I share results of this study, we'll be able to show the feasibility data. But for now, I simply want to emphasize that enrollment in trials for pancreas cancer while they're receiving chemotherapy can be challenging. And it has certainly given us food for thought as to where we want to take this next steps. Do we want to think about focusing on during chemo and then subsequently after chemo, or thinking about the adjuvant setting, et cetera. And these are all things that we are in the planning phases now to keep in mind. Ultimately, what I'd like to conclude on is that this still is a very high risk, high need population where skeletal muscle mass is a serious health risk when it is sarcopenic or cachexic. So this type of population is in very high need for interventions. So we do hope we're able to discern and really understand how we can enhance enrollment for trials to this population. And on that note, thank you so much for your time.